Kevin Lavery here. We're lucky tonight to have Dr. Paul Ernest share what he not only is passionate about, but he lives for. Clint Simpson was going to moderate, and he had a family event that pulled him away. I hope those of you who have survived the storm so far are doing well. For those of you who are about to get hit by the storm, I wish you well. We had some big rollers come through Michigan with maybe even a tornado or two. I don't know. But Dr. Ernest, we all have passions, and it might be honeybees or gardening. Well, Dr. Ernest is premium services, wound construction, and finding the best premium IOLs. And I had the pleasure of hearing this talk once before, and it blew me away, and went back and had a recording and listened to it again. And it's just, there's so many valuable pieces of information that I learned from this man that I was glad he was willing to come on and share it with you. Because unless you're in the clinic with him or happen to get one of his lectures or be there, you don't get to see in action. And this is what he lives and he's good at, and I always learn from him. So, Paul, thank you for doing this tonight.
Thanks, Kevin. And hi, everybody. Thanks for taking time out of your evening to listen to this. And I want to try to keep it as efficient as I can and open it up for any questions later after we're done. So the title actually came from a conversation with Terry Jess. We were talking about the three things I was most involved in, and I said, yes, it's like a three-legged stool. So that's where the title comes from. Let's change the slide, please, Rachel. Next one. And everybody knows that you have to have three legs that are of equal length. If you don't, the stool falls down. So to me, and what I practice now, it's wound construction, the femtosecond laser, and the Vivity lens. This to me are the three equal legs in my surgery. Next slide, please. So wound construction is leg number one. Next slide. When you think of a wound, the main purpose is to stabilize it mechanically until fibroblasts can seal it histologically. In the eye, we have a secondary purpose. We have to avoid creating an undesirable refractive result, especially for premium lenses. Next slide. So the key factors to give a higher level of performance in cataract incisions include geometry and location. There's one thing that's not on this slide, and that's the size of the incision. And I'll show you why it's not on there later on. Next slide. So science has taught that square wounds are both mechanically and refractively stable. Next slide. So this is an experiment I did. For those of you who don't know me, my background is science, engineering, and mathematics. So everything that I do has to do with setting up protocols and studies that minimize variables so that you can see what one isolated variable will do in the outcome. So what I did here is I got some cadaver eyes and I made different types of incisions. Several of them were square, as you can see, and some of them were rectangular. And I took a straight pin with the blunt edge as a plunger and put it into a force gauge. And I applied pressure to the posterior aspect of the incision to see how high I could go before it would leak. And what I found was on the square wound, you get up to the maximum of 525 pounds per square inch, and there was no leakage. When you went to the rectangular wounds, you got leakage, and it was IOP dependent. The higher the internal pressure, the more resistance it could take. So how is this applicable to what we do? I tell my patients there's no restrictions after surgery. If you could push a pin on the back of the incision and not get a leak, there's nothing the patient's going to do from lifting, bending, rubbing their eyes, or anything else that's going to cause this incision to leak. Next slide, please. Well, this study was kind of repeated by Dr. Maskett, a friend of mine from California, that took two types of incisions, square versus rectangular, and he left them at the same pressure at the end of the procedure and then came back and rechecked the pressure in 2 and 6 hours. He found the square one maintained a pressure of 19.2, where the rectangular one fell to 16.6. That means there's a small leak. It's not noticeable, but to look at the slit lamp, but it wasn't tight. Next slide. So then I wanted to take a look at the location. Well, if you're going to take a look at location, then you got to get rid of the square, because otherwise you have too many variables that are favorable to wound integrity. So I went with a 3 by 1.75 incision. And on the left, I used cadaver, and I showed that you got better resistance if you moved it back to the limbus versus the cornea. But the right was done at Wills on cats. And Richard Tipperman helped me on this, and then Ralph Eagle where we sacrificed the cats and took the eyes and looked at them histologically. If you look at the slide on the right, you can see that the corneal incisions didn't offer much resistance to pressure all the way out to 12 days. But if you take a look at the diamond shape, which is the posterior limbal incision, which was rectangular, you start seeing significant resistance and pretty complete by day 7. Next slide. So here's taking a look at this histologically. In 7 days, the corneal incision showed no healing at all, where the limbal incision was completely sealed at 7 days. Actually, the corneal incision didn't seal till after 30 days. So somewhere between 30 and 60 is when it sealed. And it comes from the fact that the keratocytes underwent a metaplasia and became fibroblasts. So why is this important? So now I tell patients you can go swimming on day 7. Prior to that, got to be a little cautious. But also when one of my retinal partners wants to do a retinal procedure 2 weeks after I do the cataract so they can repair a macular hole, I don't need to put a suture in the eye for them to do that secondary surgery where you would if you had a more corneal incision. Next slide. So here's the technique. I take a crescent blade, tip down, start between the limbus and the sclera, and I make a linear groove. And then on the upper right, I dissect it into the cornea. I really outline the square configuration with the crescent blade. Then on the lower left, I take the keratome blade, and all I want to do is perforate into the anterior chamber. I do not want to extend this any longer. And then you can see the square configuration in the lower right. Next slide. Post-operative, this is what it looks like. You can see the vertical groove. And Dick McCool, a friend of mine, also was using the same incision at that time. Next slide. So in 1992, I gave a talk at ASCRS, really talking about the effect of wound construction on astigmatism, both the surgically induced and also the axis of astigmatism. I really didn't put the right title on the paper that came out 2 years later, calling it a corneal lip tunnel incision. Really didn't describe what this was. I should have entitled it what I just said, the effect on astigmatism and the axis. Because what this showed was that there was little to no change in the axis of the astigmatism, as well as a very low surgically induced astigmatism. This didn't get a whole lot of attention because in 1992, there were no toric lenses. I looked up, the first toric lens came by Star Surgical in 1998, and Alcon didn't have theirs, which was the single piece, until 2006. So this information kind of was way ahead of its time and really didn't have any impact. I'd like to see this revived. Next slide. And then a friend of mine, Rupert Menapacci from Austria, also repeated this study and published it in 96. And he again confirmed that there was very little induced astigmatism and very little, if any, change in the axis of astigmatism. Next slide. So this brings us to the modern day incision. And I worked with Warren Hill and Rick Potvin, 2 friends of mine. And what Warren had, we had a website where you would put in your data, describe the incision that you're doing, describe the pre-op case, the post-op case. He helped with the calculation for the lens. And we wanted to compare the posterior square wound of 2.2 versus a clear corneal incision of 2.2. Next slide. So there's 1,700 eyes available. We wanted to have at least 20 eyes per surgeon so we would have enough data points to make it statistically reasonable. And there were 246 eyes from 5 surgeons that met all this criteria. And then we did vector analysis to determine the surgically induced astigmatism. Next slide. So here we are. So I found that my SIA was a quarter diopter, but the standard deviation was only an eighth diopter. If you look at the other 4 surgeons, they're at least a half, and the standard deviation was at least 0.4, which means you're getting up to at least 1 diopter of induced astigmatism. And surgeon number 2, look at his outcomes. He had 40 cases, so he had a lot of data points. His mean SIA was 0.88, and the standard deviation was 0.59. So he was getting up to 1.5 diopters of induced astigmatism from a 2.2 millimeter corneal incision. So when I mentioned earlier that the size of the incision is not a positive influence, it isn't. You can get a lot of astigmatism from these smaller wounds. Next slide. So we did a graft, and again, you can see visually just how dramatic it is. And you have to ask yourself, so how is surgeon number 2 planning his treatment plan? If you're going to induce anywhere from a quarter up to 1.5 diopters with the potential to go to 2 diopters, how can you plan for that? How are you going to treat it? What kind of a lens you're going to use? What kind of LRIs, if any, you're going to perform? There's too much variability. Next slide. So this is the results, that we were about a third of the SIA by using the square posterior limbo, and we were again about a third of the standard deviation. So the location of the incision is far more important than the size of the incision. Next slide. So to have a high SIA and a wider standard deviation gives you a problem determining the amount of astigmatism to treat and determining the axis of the astigmatism to treat. Next slide. So here's an example from one of my colleagues who's an excellent surgeon. He performed surgery with a toric lens using a 2.2 millimeter corneal incision. And his target was 80 degrees based on all the pre-op measurements. And the lens rotated clockwise to 70 degrees on day 1. So he ran the astigmatism fix formula from John Berndal and Harden, and now the new axis is 90 degrees. Well, for every 10 degrees you're off, you're going to lose 30% of the effectiveness of the lens. So what's the difference from the lens rotating 10 degrees clockwise? If it would have stayed at 80 degrees, he still would have been 10 degrees off because the incision or the axis of the astigmatism rotated 10 degrees counterclockwise. That's the take-home message. And as Kevin tries to get all of us to do more and more premium lenses, you can't be leaving patients with 3/4 of a diopter or more post-op and get to have them be happy with their surgical outcomes. It just won't work. Next slide. So why isn't everybody using it? Well, it's more difficult to use. And the main problem is ballooning of the conjunctiva. And I still get an occasional case of this. And when it does, you stop and you come out. You don't try to finish what you're doing, and you make a mini peritomy. And that's the end of it. And you don't have to cauterize it or do anything else. It goes right back into position by the next morning. Fortunately, with the smaller incisions and the better sleeves over the phaco needle, we're really getting less and less of this. Next slide. So in summary, you have statistically significant lower SIA for 2.2 millimeter square posterior limbo incisions. You have little to no shift in the axis of the axis of the incision, and you also have a lower SIA, which improves your surgical planning. Next slide. So that takes care of the wound construction leg. Now we go to the femtosecond laser. Next slide. Our group was fortunate to get the first one in Michigan and the 14th one in the world. Fortunately, we've upgraded it many times over since that time. And I did a paper with Ike Ahmed's group out of Toronto. It was very interesting. I had a hard time getting companies to sponsor this study because I used products from 2 different companies. So they refused to sponsor this. But I came forward on this. And he had a guy named Marko Popovic, who at that time was a fantastic statistician, who subsequently has gone on to become an ophthalmologist. Next slide. There was a lot of negativity on femtosecond lasers, and there's many publications that there's no statistical difference regarding refractive error or uncorrected vision between femto laser assisted cataract surgery and manual cataract surgery. And that's why it actually went down in enthusiasm on the part of fellow surgeons. Next slide. But what we as ophthalmologists are not real good at is understanding higher order aberration from the Zernike-Polynobles table of higher order aberrations, and in particular coma. Coma is named after comet. It's a ball with a tail, and the tail is the flare, and it's the flare you get that causes problems, both in the reduction of contrast sensitivity as well as dysphotopsias. Next slide. So I set up a study. At that time, we only had Symphony lenses and Restore 2.5 lenses to compare. And I did it with both manual rexes from a very good surgeon in the group, as well as femtosecond lasers from myself. And we looked at the centration of the lens with regards to the visual axis, which is angle alpha and kappa. We looked at internal coma, which has to do with a micro tilt from the overlap of the anterior capsule. We looked at the refractive error of each group. We had a standardized patient satisfaction questionnaire that was suggested by Rick Potvin to give to each member of the groups. And then Dr. Popovich performed a statistical analysis of the results. Next slide. Well, we confirmed the fact that there's no difference in uncorrected visual acuity and best corrected visual acuity between the two groups. No difference in post-op refractive error, and angle alpha and angle kappa are pre-op findings, not post-op findings. Next slide. So if you just go to the bottom one, I won't go through all the little data. The p-value was less than 0.05, which was statistically significant, and we were running less than half the internal coma with the laser, and we were running about a third of the standard deviation. Next slide. Then you look at outliers, which is internal coma greater than or equal to 0.4 microns. In the manual group, there were 7 out of 50, which is 14%. In the laser group, there was only 1. And that came from a split in the anterior capsule. If that capsule didn't split, it would have been 0. So I looked at other surgeons, and they had outliers up to 40%. So definitely the laser was a huge advantage. Next slide. Then we started photographing these outliers. And in the top slide, you can see as the amount of asymmetrical overlap increases, so does the amount of internal coma increase. So you have 1 to 2 clock hours in the upper left, you only had 0.7 microns of internal coma, which was above 0.4. When you went to 3 clock hours, it's now 1.6. And when you went to 4 clock hours, it was 2.05. The lower picture shows the one that had the split in the anterior capsule. The lens is well centered, but as that capsule contracts, it's going to have a little unevenness and induce the coma. Next slide. This is how we want it to look, where you have a nice overlap with the anterior capsule, and look at the microns of internal coma, 0.023. Next slide. So this also is pupil dependent. So under bright lights, when the pupil's small, it doesn't show up as much, but when you get into mesopic conditions, then it becomes much more noticeable. Next slide. So they did a computer generated with a monofocal lens showing this. And on the left hand, that's the low coma, on the right is the high coma under bright lights. You can see that on the right it's slightly blurry compared to the left, but it's not terrible. Let's go to the next slide. Well, let's go under mesopic conditions and take a look at lights, and you see this flare. So at the time we're doing multifocal lenses, and we get rings from the multifocal lenses, to put flare on top of each of these rings will explain why patients were not happy. Next slide. So the question is, does it really matter? I mean, does its increase in internal coma really impact patient satisfaction? Next slide. So Rick Potvin directed me to a paper published in 2010 where 30 questions from 10 categories were responses ranging from 0 to 3. Excuse me. 0 was not a problem, 1 was mild, 2 was moderate, 3 was severe. And look at all the categories: glare, halo, starburst, hazy vision, blurred vision, distortion, multiple images, fluctuation in vision, focusing difficulties, and depth perceptions. And each one of these had 3 questions. And I had a minister in the group handle this. Again, you want to limit the amount of variability, and he has a very calming voice, and he was asking these questions. Next slide. So then I get this data, and my first reaction is, wow. Here we have coma of less than 0.2, and we have results anywhere from 0 to 45. So 0 is the best. In other words, they had no complaints on any of the categories whatsoever. 90 would be the worst. So I brought some of the patients in, and I asked them, especially the lady who had a 35, I said, why? She said, well, I was under the impression there'd be no halos at all. Well, that was not part of the pre-op consultation. Another one, so she gave 3s in each one of those categories to raise the points. Another one thought she'd be able to read without glasses in spite of Symphony and Restore not giving that capability. So she gave terrible results on each of those categories. So expectations was a large part of this, but there is something that is noticeable here. Anybody that had a coma score higher than 0.4 never got below 20. So 0's the best, and 20 is so-so, and nobody with higher coma could get one. So you can get anything from low coma, but you couldn't get excellent results from higher coma. Next slide. So that led me to another analysis I asked to be done. And that is, let's take people that had great results, satisfaction-wise, of 0 to 10, and what percent of them had internal coma less than 0.2, which is well within the normal limits. And 100% of those was 0 to 10. That means out of 30 questions, at least 20 of them were 0, and at most 10 of them were 1s. And then I took a look at scores of 11 to 20, which is still excellent results, and 93.1% of those had 0.2 or less. From 21 to 30, it suddenly starts showing up that only 60% were under 0.2, and if you had higher than 30, only 46.7 were under 0.2, and the p-value was less than 0.001, which is highly statistically significant. So those with the great scores had the better coma scores. Next slide. So in summary, there is definitely a direct correlation between the overlap in the anterior capsule and higher order aberrations, namely internal coma. The more symmetrical the overlap, the lower the coma. The laser gives a more symmetrical overlap. It's by no means the only way to get it. And internal coma affects the quality of patient's vision under mesopic conditions. And patients with higher order aberrations due to internal coma can have low refractive error and good visual acuities using a standard eye chart, yet still be unhappy with the quality of their vision. I just wonder how many patients you've seen over a period of years who read the 20/20 line are unhappy. And that's because we're not looking in the right directions to find out why. Next slide. So that brings me to leg number 3. I've had a pleasure and an opportunity to use many different lenses. And Kevin knows I have a real affinity for the Vivity lens. Didn't start that way, but it sure is growing into that way. And I'll go into that now. Let's go to the next slide. Extended depth of focus means that when you have something from distance that's on the focal point of the macular area of the retina, and you bring it on in, you still are on the macula. Where on a monofocal lens, you get a blur circle when you bring it in. That's why people with monofocal lenses cannot read. Next slide. So what you really want to have is a channel that's very narrow without any of the light rays going outside of the channel for this depth of focus. That's the ideal. Next slide. Now, multifocal lenses have a channel, but they also have rays outside of the channel. And those rays is what causes the halos. Next slide. So wavefront shaping is modifying the surface of the lens so that you basically have a channel and you have a halo profile similar to a monofocal lens. And what this technology does, instead of segmenting light like a multifocal, it stretches light. Next slide. And it's called X-wave technology in the Vivity lens. And you can see as light passes in, some go straight through and others are delayed, giving you that elongated, extended depth of focus with a natural depth of focus. And the laser is important because the technology is only 2.2 millimeters of central zone, and you have to make sure it is lined up with the fovea. If it isn't, you end up getting ghosting. Next slide. This is what the lens looks like from oblique lighting. If you look at it straight on with a slit lamp, you'll even see this imprint. Next slide. What's also interesting with this lens is you have quite a wide landing zone, anywhere from +1/4 or +1/2, all the way to -1/4 or -1/2. And you get very good reading until you get inside 20 inches. Then it falls to about 20/40, 20/50. So I tell patients with this lens that you can function from 20 inches out without glasses. If you're inside 20 inches and it's larger than newspaper print, you're still without glasses. If it's smaller than newspaper print, like a footnote or a medicine bottle, you need 1.25 readers. Next slide. What's also interesting with this is the fact there's no gaps in the light. Similar to a monofocal lens, but monofocal just doesn't go that far. You can see the Symphony lens with gaps. You can see the Panoptics with gaps. The Vivity doesn't have any gaps. And you could do a modified monovision of -1/2 to pick up an extra half diopter near. So instead of having to stop at 1.5 diopters of depth of focus, you can go all the way to 2 diopters. Next slide. From a standpoint of vision under bright and dim light, it was equal to monofocal lenses for distance, arms way ahead in the mid-range and also ahead in the near. Next slide. And as far as visual disturbances, it's the same as a monofocal lens with regard to glare, halos, and starburst. Next slide. So originally, when the vice president and the guy who developed this lens and the project manager gave a call and wanted to go over it with me, I actually had kind of a negative view on it. I said, why would anybody want this lens if you can't read with it? This leads to something that I've talked to Kevin and others about. We as surgeons are kind of programmed, and we're programmed that everybody should have great distance if you're going to pay money for a lens, and everybody should be able to read with a lens if you're going to pay money for it. Well, I was wrong then, and I admit it. You don't need those things. I now use Vivity between 60 and 70% of all my surgeries. It outpaces multifocals about 200 to 1. It even outpaces monofocal lenses about 3 to 1. Next slide. Vivity gives you the vision similar to a 45-year-old without any side effects. No halos, no dysphotopsias. So I kind of joke with patients. I say, no, I can't make the rest of your body 45, or I'm going to jump ahead of you and get mine done first, but I can get the eyes back to 45. That seems to resonate with them. The light is stretched, not segmented, and you get up to 1.5 diopters depth of focus. And as I stated earlier, you can function without glasses from 20/20 to distance with no promise of 20/20. And then you'll need low-powered readers, usually 1.25, for material smaller than newspaper print inside 20 inches. But the one thing that I'm having so much fun with is that you can vary the focal point of the Vivity to match the patient's lifestyle. It's not set everybody for distance to 20 inches and move the non-dominant eye half diopter towards myopia. You can set both eyes for -1/2. You can set one eye for -1 and the other one to emetropia. You can set both eyes to -1. You can vary it any which way you want without having any dysphotopsias. This is the beauty of this lens. You can't do of anything else other than a monofocal, but you don't get the depth of focus with a monofocal. Next slide. So I call Vivity a monofocal lens with extended depth of focus. You can use it wherever you use a monofocal lens, but there are some exceptions. People who have very poor visual prognosis, you're not going to ask them to spend money on a Vivity lens. If you have diplopia requiring prism for all ranges of vision, again, it's not desirable to put in a Vivity lens. And if you have high corneal coma, whether it be post-refractive or for other abnormalities of the cornea, don't put this lens in because you will get ghosting. I fell into that trap on one patient in the past. Next slide. These are patients who you wouldn't put in a multifocal, but you can put in a Vivity. Moderate dry eyes. Fuchs corneal endothelial dystrophy. I have a lot of those patients. Epiretinal membranes with good visual potential. Previous LASIK with low corneal coma. Previous RK with reasonable topography and low corneal coma. Minimal visual field defects. Recent macular hole that's scheduled for surgical repair with favorable prognosis. Stable ARMD and macular drusen with good vision potential. OCD patients who are obsessed with minimal imperfections in their vision. And patients with glare complaints that have minimal cataract changes to justify it. This is where this lens is wonderful. Next slide. So let's talk about monovision. Next slide. As you know, monovision has been around for a long time. The distance eye gets all the light energy in the distance bucket. The near eye gets all the light energy in the near bucket. And neither eye gets any light energy in the middle bucket. So a long time ago, I tried to figure out ways to get light energy into the middle bucket. So I've tried multifocal lenses in the distance eye, where you give up a little bit of the light energy and put it in the middle. I thought, there we go. Well, that didn't go over too well. What I learned pretty soon was patient expectations. Patients don't mind getting something extra as long as you don't have to give up something to get it. So if you take something out of their distance vision or their near vision to put it in the middle, they're not happy for what they got. They're unhappy for what they gave up. Next slide. So Vivity answered this by putting it in the distance eye or the distance bucket and then have a natural depth of focus of 1.5 diopters. You now give them the middle bucket. And you gave them the middle bucket without taking one thing away from the quality of the distance vision. Now you're having patients getting something extra they didn't have to start with, and better than traditional monovision. Patients with monovision thrive on the Vivity lens, especially in the distance eye. Next slide. So what about the near eye? Well, the near eye, I like to set it from -1 to -1.25, giving you a depth of focus to -2.5 to 275. And when you combine that with the distance eye, you now have both eyes giving you the middle, the distance eye having the distance, the near eye having the near. And it's perfect. I have several optometrists with this combination. Now, if you can't afford two Vivities, then put a monofocal lens in the near eye targeting -2, and then put the Vivity lens in the distance eye, giving you distance to -1.5. That's my fallback on somebody who can't afford two of these. Next slide, please. So Dr. Cunningham is from the Saline Tecumseh area in Michigan. He came to see me. He's a monovision contact lens wearer, and he wanted to have surgery. So I set him up in January of 2021 with the Vivity toric in one eye and the Vivity lens in the other. And he wanted more than -1 in the near eye. He wanted -2 so he could get up to -3.5 and read the dials on his 4-opter without glasses. So that's what we did. It turned out 2015, fully corrected. And he's just really, really pleased. Next slide. So he sent this little message. I'm still waiting for my hug, but he sent me the slide basically saying how happy he was. Next slide. And he now did a video for the practice, and we'll have Rachel play that for us now, please.
My name is Dr. Tom Cunningham. I'm an optometrist, eye care specialist in Tecumseh, Michigan, and Saline is where I practice. And my typical day, I start by looking at my schedule, and we run the patients through their preliminary workup, and then they come back to visit me into the exam room, and I go to work trying to take care of their visual needs. If I can help them, we fit them with eyeglasses, contact lenses, we check for diabetes, we check for glaucoma, and many other eye conditions that can happen. It's imperative to have good vision as an optometrist because you have to relate to your patients, you have to fit them with glasses. It's just very important with your everyday activity to have good vision. I've always had vision issues ever since I was in approximately 6th grade. I was nearsighted, and as I got older and got into college and then into optometry school, I found out about contact lenses, and contact lenses were wonderful for my type of activities. Yeah, what happened was a typical situation with a patient, they'll come in one year, and when you've been seeing patients for years, you'll notice a slight decrease in their vision, but you can correct them with glasses, and you notice that their lens in their eye is changing, okay? The lens of the eye is internal, and it changes color, it gets more yellowed, more foggy as you get older, and I was having this continual change too with my prescription, yet I could see 20/20. But 20/20 is not the end-all be-all. There's 20/20 good vision, 20/20 bad quality vision. Plus, I was seeing many blue and yellow halos around lights at night, and I knew that was something that I had to address. And that's when I said, it's time for cataract surgery. I chose Specialty Eye Institute because I've worked with them for many, many years. I've worked with all the doctors there, and I think they're very excellent surgeons, and they've all been very receptive to try to help me in my quest to give my patients the best care possible. And when I could not do it myself with my vision specialties and my skills, I have to send them on. Me being a vision specialist, I thought there's so many choices. Okay, first of all, I did not like the concept of a bifocal implant because I didn't have luck with the bifocal contact lenses, and I did not want any glare. I did not want to have to determine between two different alternate areas to read. And I thought, okay, I'm going to talk to Dr. Ernest about monovision, where you get the dominant eye perfect at distance and then the other eye for reading without having to wear contact lenses. Dr. Ernest mentioned to me that, Tom, there's a new lens out, and it's been out for approximately 2 to 3 months, and he's had a very success with, and people are not talking about glare from this lens, visual side effects, and they're reading very well. And I said, wow, that sounds pretty good. So we decided to come up with an alternative to get perfect distance vision with computer distance for my right eye, my dominant eye, and for my left eye, we decided to leave me just a tiny bit nearsighted so I could get my paperwork done all the way into 10 inches. Because in the exam room, I work in dim light conditions, and I needed that. We decided that that was the best system for me. Dr. Ernest said, let's get in, Tom, let's do this. We did it very quickly. I was in there within a week, had one eye done 1 week, the other eye done the next week. After my procedure, it was amazing. I thought, my goodness, I can't believe what I've been missing. Colors were bright, whites were white. I could see up close right off the bat. I mean, I took the day off, the next day off, and went right back to work, okay? That first week was a little tough with one eye doing the work. And I said, my goodness, I'm reading after 2 days. It was absolutely amazing. I have a lot of patients that are hesitant, worried about cataract surgery. They hear all the complications that can happen. If they're having any of the issues that I had, a little bit of poor quality vision, they don't see like they used to, I'm really going to try to make them feel at ease to get this done sooner. These doctors have so much experience, they've done so many people, and you shouldn't have any hesitation to see these doctors that are so well qualified. I mean, I put my vision in their hands. I'm just very grateful that Dr. Ernest was in this area and that he really keeps up with all these innovations. It's been just a life-changing experience for me. I can't say enough about how much good quality of vision I have now.
Next slide, please. Thanks, Rachel. This is a phrase I coined called vividity in reverse. It's basically taking that extended depth of focus channel and moving it towards the cornea. Next slide. There's a lot of patients who are low to moderate myopes who like to go without glasses for the bulk of their day. And these are people that really don't do much in the distance, that maybe drive occasionally. So instead of setting the vividity lens for distance, middle, and functional near at 20 inches, let's reverse it and go near, middle, and functional distance. And I can't even tell you how many dozens and dozens of patients who now have this done. Next slide. So here's one example, 67-year-old female, she's actually from Ohio, that came up to see me, and 90% of her day is middle to near activities, only small amounts she spends walking her dog, watching TV, and a little bit of driving. She was a myope with cylinder, and we did the vividity lens in each eye targeting -1, which will give her a range of vision from -1 to -2.5. And she'll be able to do all her middle and near activities without glasses, and she'll be able to do many distance activities without glasses, like TV and walking her dog. She'll need driving glasses, no bifocals, no trifocals. She had the surgery. We met the targets and the goals, and she's absolutely thrilled. And this can be now varied any which way you want, anywhere from -0.5, -1, -1.5. Next slide. Now here's an interesting patient that was 38 years old, only had a cataract in one eye, and he's -3 myope in the other eye. So I targeted him to be about -2 to 2.5 with the vividity lens. So now his two eyes are relatively the same for reading. He has a depth of focus in the right eye similar to the natural accommodation in his left eye, and he just wears distance glasses. Next slide. I have now completed 3 patients who have ESO deviations with diplopia only at distance. When they take their glasses off and they read and look at mid-range like a computer, they do not have diplopia. So how are you going to treat these people? If you put them in a prism throughout the entire glasses, you'll take care of the distance diplopia, but now you're going to create diplopia for middle to near. But if you take the vividity lens and set them for -1, they're independent from middle to near with no diplopia, and then they wear distance glasses with the base out prism. All 3 of these patients have done extremely well with this plan. Next slide. So what else can you use this lens for? Next slide. You could do it in RK, especially 4RK. 4RKs do really well, especially if they have low corneal coma. Here's a patient that had quite a bit of hyperopia with corneal cyl, especially in the right eye. Next slide. So we did a vividity toric in the right and the vividity on the left, and this is how she ended up. Essentially very minimal refractive error. Next slide. So what about multifocals? They're not dead. I still use PanOptix and Synergy on occasions. I really like to use them in patients with multifocal contact lenses who really enjoy that multifocal vision and are not disturbed by the halos of the contact lenses. You're also going to have patients who have such high myopia or high hyperopia that with the power of the vividity lens is not available, and they prefer halos to monofocal vision. Next slide. So what about mix and match, where you do vividity in one eye and a multifocal in the other? Well, my first 2 patients were optometrists, one from Columbus, Ohio, and the other one from Owasso, Michigan. This may be a rather bold approach, but what I did was I put the multifocal lens in the dominant eye and the vividity lens in the non-dominant eye. And I've had discussion with partners on this. The reason why you got to put the multifocal lens in the dominant eye is because the patient wants to be able to read without glasses. You can't put it in the non-dominant, think you're going to have less effect with the halos. Then you're not meeting the patient's needs. So you do the non-dominant eye first with the Vivity lens and ask them how they like it. In this case, both of them wanted to have the multifocal so they could read. They did talk to each other, and I did. And then I've had 6 patients with this combination since then, and 3 more added to the schedule. So what happens is the Vivity lens mutes the severity of the halos in the multifocal eye, right? Getting half the number of halos rather. So this combination works in a limited number of patients. Next slide. So again, the 2 factors are important if you're going to use Vivity and multifocal lenses: astigmatism control and reduction of higher order aberrations, as discussed earlier. Next slide. So the way I treat pre-existing corneal astigmatism is as follows. If you have whiffed or rule corneal astigmatism up to 1.5 diopters, I'll use the laser to treat it. If you have more than that or outside of those parameters, especially oblique and against the rule astigmatism, I use a toric lens. Next slide. So in summary, the 3 legs to a consistently successful cataract surgery, and I use the word consistently because I don't want anybody to feel if you don't do it this way, you're doing bad surgery, because that's not true. Everybody's doing very good surgeries. Now we can just take it to a little higher level of consistency, and they include using a posterior limbo square incision, which is mechanically stable with rapid healing, low surgically induced astigmatism, minimal change in the axis of the astigmatism, allowing a more precise treatment. The laser gives you more precise centration of the lens with the visual axis, symmetrical overlap the anterior capsule on the optic, and reduction of higher order aberrations, namely internal coma. And the Vivity lens gives a natural depth of focus of 1.5 diopters, similar to a 45-year-old. No halos or dysphotopsias, and you have the ability to change the focal point of the Vivity lens to match the patient's lifestyle. I'll open it up for any questions.
Hey, Paul, Daniel Pierre here.
Yes, Dan.
Hey, could you put that last slide up just so we can all look at that and think of questions again? Rachel,
yes, go. Rachel, would you put the last slide, the summary slide up?
Thank you. Hey, when it comes to your posterior limbal square incisions, one thing that I might have missed that you said before was just your definition of a limbal incision versus the corneal. When I make my incisions, I go right at the limbus, but I don't take down any conjunctiva. When I was in training, I was taught that, to do a true limbal, you need to take down the conjunctiva a little bit, which is super annoying because any reflux of the fluid from the main wound while you're phacoing will go right underneath there and then cause that crazy chemosis interop. So I noticed that when you were talking about your limbal incision, you don't do that. You really go right at the limbus. But how is that different than what other people would call a corneal incision?
Well, Dan, it's a good question. A good friend of mine is Thomas Neuhan, who actually was a co-inventor of the capsular rhexis. And he describes this as an area in the limbus called conjunctiva fixa, where the conjunctiva is actually fixated to the tissue underneath it. But I really try to go at the posterior margin of the limbus, not in the middle of the limbus. And yes, sometimes I do cut through conjunctiva. Now you can get around that by making the cut through the conjunctiva wider than the incision. You also, with the better sleeves over the phaco needle, have very little reflux of fluid. And if you happen to get some reflux and you happen to get ballooning, you just stop and take a little pair of scissors and do a mini peritomy in each direction. And that solves the problem. You don't want to wait till you've got a ballooning 360 and you've got pulling of fluid on the cornea and you can't see what you're doing. That's a disaster.
Yeah, addressing it early, because that Tenon's tissue really hangs on to fluid, something terrible. And even if you make holes later on, it's not going to help at all.
No, you gotta stop. And again, it's a discipline, as you know. We want to kind of finish what we're doing, and sometimes you just have to stop what you're doing and stop a problem from becoming a real problem.
Speaking of appropriate size sleeves that go with your incisions, you're a 2.2 incision sort of guy. It sounds like from the lecture here. What color?
So actually, I've kind of changed it a little bit. I'm a little wider now, probably more like 2.3, maybe 2.3 1/2. And the reason is I was getting stripping of Descemet's membrane when you're that tight. So if you watch my incisions now, they're probably more like 2.3. And then when I enter the anterior chamber, as you know, you not only cut through the tissue, but you stretch it. So the internal width is not as great as the external width. So I back up and do just a little flare, not enough to change the architecture, but just enough to widen the innermost part. And that will decrease the stripping of Descemet's membrane.
Now, what color of sleeve are you using? An Alcon handpiece, and what color
Yes.
sleeve then? Well, is that the purple sleeve or something smaller, like a red or a?
It's not a red, so it's got to be the purple.
Okay.
That's a good question. I don't necessarily have the correct answer to you.
Yeah, because if they don't match, then you're gonna get some reflux. And over here at at Cleveland Eye Clinic, the keratomes we have in supply are 2.75, which is kind of big. And I noticed with the purple sleeve, we're getting lots of reflux, so we could probably match that up a little bit better.
Well, I know we're getting technical, but one of the reasons why you get the most ballooning is on your INA if you're using a single handpiece INA. I adopted 30 years ago the European bimanual INA, and I love it for so many reasons. We're probably going to bore many of the people on this call with all this technical stuff, but I can clean up all the cortical material, including the subincisional, and polish it. And that will also not balloon the conjunctiva. When you use your single handpiece INA, you start getting ballooning.
Now, doesn't that require a larger paracentesis wound then?
Just two of them. I use the German Guder handpieces, which go through a 1 millimeter paracentesis. Other companies have to have a little larger than one, and then that's an issue for me. So I have a 1 millimeter keratome blade that I use to make paracentesis.
Okay, so you sacrifice and do one extra incision for that, but that's, again, it's a small incision is free, right?
It's free, and again, technically, you have to really hydrate those more than the cataract incision, which is self-sealing, because you have ovalized those paracentesis incisions with the hand pieces. So if you have to make sure that they don't leak.
Yeah, makes sense. Now, you're using the femtosecond laser a lot in these patients. Do you use it for every single cataract surgery?
No, they have requirements, as you well know, when you can use it. You have to use it to treat significant astigmatism or to center a premium lens. Fortunately, I've been able to do a lot of premium lenses, so that's why I use it with that.
And there's a pricing structure that's separate than the lens package, or does it go along with?
Our package for the Vivity lens includes the laser price.
How is with the Vivity lens there? Again, I know I'm getting into a lot of details here, but I'm just curious. Do you speak of the Vivity lens like is it the same as your multifocal package, or is it like we have like what we call like a driving package where we take care of the astigmatism down at our place, but like or is it structured a little bit differently?
We have structures for multifocal lenses, which include the femto. We have a structure for the Vivity lens, which includes the femto, and they are different price points.
What about like a like a toric lens that's not the Vivity, or you don't even bother?
Yes, you can. We have a price point for the toric lens alone, monofocal toric, and we have a price point for the toric lens with the femtosecond laser, which I tend to use in patients with astigmatism that have Fuchs corneoendothelial dystrophy. I really believe, and I have lots of anecdotal proof, that you reduce trauma to the corneoendothelium by using the femtosecond laser in people with pre-existing endothelial dystrophy. I have pictures of those that didn't have it, and they show a worsening even if the cornea is still clear. And I have pictures of those who do have it that show minimal to no change. So I really try to use it on Fuchs patients. And if they have too much astigmatism, to correct it with the laser alone, then I use a combination of toric and femto.
Thank you.
Any other questions?
I have one question for you. When you're talking, just for more of like the clinical world, maybe not the doctors on here, but when you're talking to your patients and you get asked the question, why do I really need this lens? Why is this lens? I mean, I know you just went into great detail why this lens is so superior and why this is a benefit to the patient. When someone's saying, I'm 80, do I really need this lens? What is your, what's your feedback to them?
Okay, well, I actually have Sarah, who actually works with me in the exam room, sitting right here next to me. So this is basically what we do, and Sarah can add anything she wants to on this. What I spent a lot of time doing, Rachel, is I ask questions about their lifestyle, and I have the 3 buckets up there on a poster. So I start talking about, let's talk about your distance bucket from 20 feet and beyond. I want to know if they drive. I want to know if they drive at night. I want to know if they play golf, tennis, or pickleball. I want to know if they shoot a gun, fish, do bowling, do swimming, that type of thing. And I get a feel for that. Okay. And then the next thing I want to do is talk. What I really want to know about is that middle bucket. What are you doing between 20 inches and 20 feet? Are you on a computer? Do you play card games or board games? Do you do arts and crafts? Do you do woodworking? Are you somebody that's reads sheet music? Are you either to sing or to play a musical instrument? This is important to me because if they're not doing anything to speak of in the middle bucket, I don't even talk about the Vivity lens. They don't need a Vivity lens. All they need is a distance lens and we're readers. And then I want to find out in the near how much time they actually spend inside 20 inches reading. And that would include, I want to make sure they're not including the computer, which tends to be in the middle bucket. So I want to know if they're spending 0 to 5 hours a week, 5 to 10, 10 to 15, more than 15. And then I start saying to them, so is it correct in assuming that you're spending the bulk of your day between middle and near? Then I look at their refractive error. Are they a myope or a hyperope? If they're a hyperope, I'm probably not going to advise Vivity in reverse. But if they're a myope, I will. And then I ask them the question, is it more important for you to be able to function without glasses for distance or more important for you to function without glasses for near? This is a long consultation. I don't see a ton of patients. I probably see up to 10 patients in a half day. But all this information kind of goes into one's computer brain, and then you can get an idea of what will work for them. This is matching the technology to the lifestyle. I do not turn this over to Carissa, who's also sitting in this room with me right now. I want her to do other things. I think it's my job and responsibility to match this technology. Then we get into the discussion, and we also explain why I don't think they would be a good candidate for a multifocal. I then explain a monofocal lens that is an option for everybody. I let them know you're not going to be able, if I set you for distance, just to go and wear readers, especially if you're very busy in the middle bucket. You're going to need 2 pair of readers, one for the middle and one for the near. And that can be in any form from looking over the top of a pair of split glasses or wearing trifocal glasses. And then there's a cost to that. So even though the lens doesn't have a cost, there's cost to the hardware afterwards. And then we get into the Vivity. I always save the Vivity option till last. I always say I want to basically save the best till last and so on. So and everybody's different. So, we had a great day today, with people accepting the Vivity lens. Some days we don't. But it's not, we're not here to force them into anything. It's still their choice. But they appreciate the fact that we take all this time and really match the technology to their lifestyle.
Yeah, I think that's great. I think the importance is on the education and making sure that everyone, both us as counselors and as people in their lives that know a lot more about eyes than they do. I think it's super important to give the education and help show them their options. I think it's great.
Any other questions?
I got one more question.
Yes, Dan.
If you had to saw off one of your legs of your stool, which one would go first?
None of them.
Come on, you got to pick one.
That's like,
No.
which child do you like the least?
No, Dan. Actually, I've been looking for the lens that would match the other 2. Obviously, I had wound construction for a long time, and then, I tried my best to be really good at manual rexus. Then I saw the laser, one of my optometrists that referred to us said, "What the heck do you need that for? You'd make a very good manual rec." I said, "Yeah, but there's potential here." And so that was step two. But the lenses, as good as the multifocals have gotten, still have their drawbacks. And many cute anecdotal statements. I don't know how many of you are aware of Mark Whitten. Mark is a famous LASIK surgeon who operated on Tiger Woods and many other athletes. He was a very good friend of mine, was with me on a very tragic day in my life. And Mark had a Panoptics put in his right eye. I didn't do it. And he had a lens put in his left eye, also, which I didn't do. And he was doing Panoptics, a lot of patients, and he and I played golf together. And I was telling him about the Vivity and why I use it. So last fall, when he came up, he said to me, "Well, Paul, I came over to the dark side." So I'm kind of looking at him with a strange look, like, "What are you talking about, Mark?" He says, I use Vivity all the time now." And I talked to Bernie Kelly up in MEI, and he now has changed his emphasis from multifocal to Vivity lenses. And talked to Les Grossinger, and he has shifted from Panoptics to Vivity. So I just haven't reached enough of you guys yet. So if I do, you'll probably be shifting more to the Vivity and less to the multifocal. I did ask Endicott, not directly, but indirectly through his number two person, when he's going to quit making multifocal lenses and start making more Vivities as his priority. I don't think that reached Dave Endicott yet, but I really believe that Alcon has a tremendous, powerful product here. They are working on a Vivity 2 suggestion I made for them. I don't know if it's going to come out or not. They're going to try to get another half diopter of depth of focus, but they have to make the pattern a little wider, and they want to make sure that doesn't take away from the quality of the distance to do that. So that's not available yet, but it's in the works.
So your your patients that have never had monovision before with the Vivity, in your opinion, it's a safe move to go ahead and do that mini mono with the Vivity.
A half diopter is fine. They're not going to notice that down.
Okay. But what about aiming for like the -1 or even the -2?
Well, no, they've got to be a monovision patient before I would go that direction.
Okay. So it's really a half diopter. And again, that gets you your 20 inches, right?
Yes. No, half diopter will actually get them more like 18.
Okay. And so that's free for everybody. So what about your patient who's like, "Oh, monovision. No, my brain couldn't handle that." You're like, "This isn't quite monovision." You describe it in a slightly different way then?
Yeah, I do not use the term monovision because it's not. I don't even use the term modified monovision because they'll hear the word monovision. I just basically, what I do is I like show and tell. So I have two indirect cases on my bench, and I put them out there, say, "Okay, here's distance of 20 inches. Now we can move both of them in this direction, give up a little distance, like about a half a line to a line, and pick up another 2-3 inches." So you bring up another point, which I didn't mention, is a lot of times I do the dominant eye first. And then I ask them how they're doing at the bedside. I want to make sure they don't pop a lens out and try to use both eyes together. Otherwise, they can't answer this. And then at the bedside, I ask them, "Well, how's the first eye doing?" I expect to hear that they've done well for distance. And I said, "So do you want me to match that, or do you want to give up a little distance and pick up a few more inches of near?" This is a individual consultation. So all these second eyes, Carissa, who's here with me right now, we've come up with a plan on the surgery schedule. We do all the monofocal lenses first. There's no reason to make those wait to the end of the day. Then we do the ones that don't require markings, like femto no arcs with the Vivity second. And then we save all those second eyes that I have choices till last, so that I can spend that little bit of extra time without making an entire field of surgical patients wait longer. And this has been a great way to approach it. And every patient gets that little bedside discussion.
That's nice with the logistics. A very nice touch.
Thank you. You're more than welcome to come and watch us in action, Dan.
Oh, that'd be so fun if only I had time.
Right. But that's also the trap we fall. We're all so busy, we don't take time to learn and stuff. But we're over our hour, and a lot of people are giving up their evening. Paul, you don't fail. I still learn from you. Thank you. Daniel, thank you for putting this on. Rachel, for helping out, and Chris and Sarah there, who's the tech support team. But thanks all for being on this call. There is a lot more education pieces coming to help everybody in the process with the education piece, because that is so vital to getting patients, the best lens for them. And they don't know what the best lens is unless we fully, I think, educate them fully. So Paul, thank you. Everybody enjoy their evening. Reach out with questions. You can just email me if you have questions, and I can get answers from Paul or anybody else. But I truly thank you for being on the call tonight.